Yeah, so I'll go straight to my topic, which is wide field imaging in severe NPDR. So before we get into that, we'll get into some of the definitions of what the fields of view. So traditionally, the fundus cameras have been able to capture the central 30 to 50 degrees, which approximates to 15% of the retina. Then you have the 7-field, which is advocated by the ETDRS study, which capture up to 30% of the retina. And now you have the ultra-wide field, which is defined by the DRCR net as anything more than 100 degrees. And currently the widest that we have is the Optos, which captures 200 degrees, that is up to 82% of the retina. So this is this was the standard 7 standard fields which was used in the DRS and the ETDRS study, which captures most of the DR lesions that we see. And in certain countries like the UK, they use the 2 45-degree fields, that is one fovea-centered and one disc-centered. This is the method they use for DR screening, which also captures most of the lesions that need treatment. So now with the advent of ultra-wide field imaging, we have the peripheral field, so that is something new. There's more area that we can image, there's more area that can be captured on a fundus camera, and these have been divided into peripheral fields 3 through 7. So as the picture, it's self-explanatory. The third peripheral field is temporal to the macula, 4th and 5th in the supratemporal, infratemporal quadrant, and 6 and 7 in the supranasal and intranasal quadrant. So this is the Optos field image, which showing the ETDRS grid and overlay along with the peripheral fields. So what the earlier studies had shown, that around 11.7% of NV were actually located only outside the 7 standard fields. So there's a small percentage of patients that we actually miss PDR if you are doing only the 7 standard fields. And angiographically, you can catch more lesions, and that is around 16%. But still, majority is within the 7 standard fields. This is a picture showing predominantly peripheral lesions. So we'll come to a couple of cases. This is a patient, 57-year-old male, long-standing diabetic. He came to us, and the picture shows NVE in the right eye. And the left eye, the posterior pole was okay, fairly good vision. This was his wide field image. And the right eye shows the NVE with the non-perfusion areas, and the left eye shows the extensive non-perfusion areas and late vessel leak. This is another patient, a 63-year-old lady, long-standing diabetic again, only on oral hypoglycemic agents. She underwent laser a couple of years back. She came for a cataract evaluation, and this was her fundus picture. And this is her wide field, showing a few hemorrhages in the periphery here, and in the temporal periphery, and inferiorly also. So we went ahead and did an angio. She was a single-eyed patient, which showed an enlarged FAZ, a few staining of the laser scars, and extensive CNP areas superiorly and inferiorly, and peripheral vessel leak. This is another patient, long-standing diabetic again. She gave a history of previous stroke a couple of years back, and she was on treatment for the same. So her right eye, this was her fundus, and the left eye showed clinically NVE infratemporal, near the infratemporal quadrant, infratemporal to the fovea. She had reasonably good vision in both the eyes. And this was her wide field in the right eye, again showing many lesions in the periphery, far periphery. Again in the left eye, many lesions in the far periphery. So we went ahead and did the angio. The angio picked up NVE much more than was what was seen clinically, along with associated CNP areas. And the right eye showed only CNP areas. There were no NVE. This is another patient, 65-year-old, long-standing diabetic, again fairly good vision. His systemic comorbidity, he was a patient of a cardiac patient, underwent an angioplasty, And this was his fundus picture. He was a myope also, showing peripheral hemorrhages. This is an artifact. It is not a vitreous hemorrhage. It was just intraretinal hemorrhages. And this is the left eye. Left eye showed NVD clinically and multiple peripheral hemorrhages in the wide field pictures. So this was his angio. The NVD was picked up, and along with that, a couple of NVEs and extensive CNP areas, which is expected. And the right eye shows macular ischemia, although the FAZ was reasonably intact, you could say, but temporal to that, there was significant ischemia and extensive CNP areas, both superiorly, inferiorly, and superiorly. So, now coming to the newer term that we've heard from Dr. Parvati, predominantly peripheral lesions. What are they? They have been defined as any DR lesion which is located outside, and any of these lesions, and more than 50% of those lesions should be located outside the 7 standard fields, and that is when it is predominantly peripheral. And that is the clinical definition. And on angiogram, it can be either picked up as peripheral CNP areas or late peripheral vessel leakage. So why do we need to know about this entity? How does it, what implication does it have, and how is it going to change our management and outlook on prognostication? So if in an eye with predominantly peripheral lesions, earlier studies had shown that there is an increased progression to PDR, and even in the earlier stages of diabetic retinopathy, there is a faster diabetic retinopathy progression. And when the lesions are seen on angiography, there's an increased risk of neovessels and macular ischemia. And how, so this question was asked, there was a study protocol AAA by the DRCR net. They undertook to answer this question, and whether detection of PPLs outside 7 standard fields could improve the ability to predict rates of disease worsening. And they concluded that the presence of fluorescein angio, a PPL at baseline, was associated with a greater risk and worsening over 4 years, not so much with the presence of color PPL. So what are the implications of PPL with the systemic association? So a study in South India, again our own group, 3 tertiary care centers, they looked at images of all treatment-naive diabetic retinopathy patients, and they concluded that the presence of PPL is a marker for coronary artery disease, and early referral to cardiology is warranted. And they also said that it's more common with increasing DR severity, and of course, it goes without saying that it's common with longer duration of diabetes. So, does DR grading action, now we are all used to a certain DR grading. We see the posterior pole, the focus is on the posterior pole, and the thing not so much in the periphery. So with this ultra-wide field imaging, does it actually change the DR grading? So when you compare the 7 standard fields with ultra-wide photography, it matched in majority of the patients. It still remains the same, but of course, and within one level, 94.5% fell into the same DR grade. And when you compare with the clinical examination, you've seen the patient clinically and then an ultra-wide field photograph, the severity matched only in 58.8%, but it was within one level in 91. So majority, we are not very far off the mark in a clinical examination or with just a 7 standard fields, but there will be, or there is a percentage of patients that we do miss without doing a proper peripheral examination or a wide field imaging. So now to conclude, majority of the lesions are seen posteriorly, so that still stands. However, we have to learn to look out for peripheral lesions, and if that is seen, baseline ultrawide fluorescein angiogram is a good option. But if that is not available, if we are able to identify this particular phenotype, we need to know and we need to be aware that they need to be followed up closely, because the progression to the subsequent stages of DR are higher. And in these patients, we should consider a cardiology consultation because the association with cardiac disease is stronger. I'd like to acknowledge the staff in our department for all the photographs that you've seen, and thank you.